Okay, I think we're gonna get started. I'll try to use my swim coach voice here. Hi everyone, welcome to Grand Rounds today. This is a very special Grand Rounds. We have the inaugural Dr. Amy Horton Memorial Lecture and Award today. We're truly honored to have with us today Amy's family, husband Richard Steingard, and children Jordan and Charlie Steingard, along with many friends and family whose heartfelt generosity and love for Amy has made this lecture and award the first award for psychology here in our department possible. So thank you very much for that. This award is given to a child intern every year. It will be given to a child intern every year. The interns are competitively selected by a group of core training faculty on the basis of their commitment to the care of children, as demonstrated through extraordinary clinical therapeutic skills and compassionate care, particularly in relation to delivery of cognitive, behavioral, and other evidence-based therapies for children, adolescents, and families. I just want to read a little bit of something that Richard and friends wrote about Amy, just to introduce everyone to Dr. Amy Horton. Dr. Amy Horton was born in St. Paul, Minnesota, but grew up in Santa Barbara. She attended UCLA as an undergraduate, Loyola Marymount for her master's degree, and the California School of Professional Psychology, now Alliant University, for her doctorate. She completed the pre-doctoral internship here at UCLA and postdoctoral fellowship at Yale. She then worked for 3 years at Metropolitan Hospital in New York City before moving back to Los Angeles. Upon her return, Amy worked at UCLA's neuropsychiatric unit, now the Semel Institute NPI Resnick Neuropsychiatric Hospital, where she co-ran the adolescent inpatient unit with Dr. Mark D'Antonio. After leaving NPI, Amy spent over 20 years as a teacher at the First School, a progressive preschool in Santa Monica, and also maintained a private practice focusing on providing treatment to children and adolescents. Professionally, Amy's philosophy was straightforward. She believed that children and adolescents were generally trying to do their best, but obstacles sometimes arose blocking their path. Amy's goal was to identify the obstacles and address them head on. She created individualized treatment plans which implemented a variety of methods and were based on a range of theoretical orientations, combining attachment theory, psychodynamic theory, and cognitive behavioral theory. Amy was clearly innovative in her approach. She believed in social storytelling long before it became a trend. She taught her young clients magic tricks, which she had learned from her father, with the idea that mastering a magical act would help them modulate their affect and create a sense of command and control. She also used puppetry, allowing children to act out their challenges through the anonymity of puppets performing in a small puppet theater that she kept in her office. She kept old phone books at her office and had the children rip out the pages when they needed to vent their frustrations. These are just a few examples of the creative ways in which Amy used to connect with her clients and direct them towards their goals. Amy also counseled parents to try to understand the complexities of their children, always emphasizing that the children's well-being was her primary concern. Amy was an expert diagnostician who was able to evaluate a child's mannerisms and characteristics, often tactfully suggesting to parents that they have their child evaluated for occupational therapy, speech, and potential autism spectrum disorders. Amy also led several groups for parents of toddlers, which were so popular and invaluable that the attendees insisted on continuing as a group all the way through high school. Mostly, Amy believed in listening. It was her superpower. Whether counseling her young clients, their parents, or many of her friends who were experiencing difficulty with their child rearing, Amy was fully engaged, patient, empathetic, and gently guiding. She was a great asset to all who sought her guidance and to the psychology community as a whole. Amy had numerous ties to UCLA, which make this award so special to her family. As already mentioned, she did her undergraduate years here, her pre-doctoral internship here, and worked at UCLA NPI for several years. She met her future husband at UCLA. Amy sat next to him in speech class her freshman year, though she later said she had no recollection that he was even in the class, but he definitely noticed her. Amy's sister did her postgraduate work at UCLA, and Amy's daughter is currently in a doctoral program here. Many of her closest friends attended UCLA, some of who are here today. In short, UCLA played a huge role in Amy's life, professionally and otherwise. For this reason, Amy's family and friends could not be happier with this tribute to someone they dearly love, admire, and miss. And it is with great honor and pride that this award is being presented to these outstanding predoctoral psychology interns here at UCLA. All right. Well, it is my honor as internship training director to announce and present our awards to Gia Choten and Caitlin Kennedy this year. I just want to say a little bit about each of them. Gia, faculty describe you as exceptional, empathetic, and quote, feels like she's reading your mind. She's highly self-motivated, and people say it's almost like you don't have to teach her. She finds resources before you even mention them. This is evident in Gia's future plans here at UCLA. She will be continuing her work with acutely ill children and adolescents in a T32 postdoctoral fellowship with Jocelyn Mesa, while continuing to spend time on our child inpatient unit. So congratulations, Gia. Caitlin, faculty describe you as stellar, thoughtful, and able to concisely synthesize things into a sentence or two, but then easily expand these thoughts to show a beautiful and deeper understanding of the case. You're very giving of your time with families, making sure to spend time with both parents and children and all the time that they need. And we're so happy to have you staying with us at UCLA for fellowship here. And he's going to be working in the perinatal mental health care in the NICU with Catherine Mogul. Inaugural Amy Horton Award. Thank you. I got to get one picture. Make sure we get. Thank you. All right. Yeah. And now I'm going to turn it over to David Miklowitz, who's going to introduce our speaker, Dr. Stephen Hinshaw.
Thanks, Patty. It's a real honor to be here and see so many people coming into this room. Rather warm in here, I'm guessing. We're all going to get to know each other very well. First, I want to thank the family of Amy Horton. I did not unfortunately get to know her in my career here, but I feel like I've heard so much about her. I feel like I know her, and she obviously is an amazing person. I'm glad that we're able to have this honor, this award in her honor, the first psychology award we've had here at Semel. Now, when we were choosing our awardee for this lectureship, we really had two criteria. We wanted a professor who had done seminal work in child and adolescent psychopathology and treatment. And we also wanted somebody who'd been an intern here. And one person's name rose to the top, and that was Steve Hinshaw, who I knew from graduate school. I actually met Steve in graduate school, I'm embarrassed to say, in 1979. We met on— Proud to say. No, proud to say. We met on a softball team. I don't know if you remember that. Could you explain to me, by the way, what getting a little dingo means?
Yeah, and our second year as a team, we weren't in A or B, but in C, we beat Navy ROTC for the championship.
Well, I remember a lot more about that softball team than I do about graduate school. Now, as most of you know, Steve is a distinguished professor of psychology at Berkeley and also psychiatry at UCSF. After his undergraduate at Harvard, he, of course, came here for his psychology PhD and his internship. Very quickly, he became one of the leading researchers in developmental psychopathology, and particularly in longitudinal studies of ADHD in women, in girls. In fact, most of what we know, I would say, about ADHD in girls comes from Steve's research. He's also an expert in stigma reduction, which is one of the things he's going to be talking about today, the negative attributions people make about persons with psychiatric disorders. It would be an understatement to say he's been very productive. He has 435 publications. He's published 12 books. And one of those books I wanted to mention is called Another Kind of Madness. This is the book about his father and his father's illness, bipolar disorder, and how it affected Steve as a young man and also his family, navigating the stigma, which was even worse, I think, in those days. I highly recommend that book to you if you get a chance. He's had numerous accolades, and I'm going to keep you here all morning if I were to mention all of them, but let me just mention a few of the highlights. He's won the Distinguished Scientific Contributions Award from the Society for Research in Child Development, the same award from the American Psychological Association, the James McKean Cattell Award from the American Psychological Sciences, the very heavily coveted Sarnaut Prize in International Mental Health, and the Ruan Prize from the Brain and Behavior Research Foundation, and also an award in mentorship. He's had many, many students, some of whom are in this room, and I really spawned a whole generation of researchers in child psychopathology. So the title of his talk today is Youth Mental Health, ADHD, Evidence-Based Treatment and Stigma. Let's give a warm homecoming welcome to Steve Hinshaw.
Well, after these incredible awards and the incredible and overblown introduction, I've cut down to 3 slides, so we'll go pretty quick. There's a lot of ground to cover, and this will be a bit of a 30,000-foot overview. Here's some disclosures: federal funding, Schwab Foundation funding, and I've published books, current books under these publishers. And so we're going to talk for a few minutes about the absolute mental health crisis facing teenage girls, not only in our country, but around the world, but especially in the US. We'll then take up ADHD, a topic I've studied for a long time before it was even known as ADHD, when it was called hyperkinesis and hyperactivity, and try to illustrate some developmental psychopathology principles, both in terms of clinical trials and longitudinal work. And stay tuned for some information on heterotypic continuity. Impress your friends with that term. And then we'll close out with stigma, which I could spend all day and evening and month talking about, that remains a huge problem: stigma and discrimination toward people with mental and neurodevelopmental disorders. So that's the agenda. So developmental psychopathology turns 50 this year. Tom Achenbach wrote a book in 1974 called Developmental Psychopathology. It sold about 12 copies. It got really hot in the late 70s and early 80s when Child Development ran a special issue on developmental psychopathology. A few years later, Dante Sacchetti founded the journal Development and Psychopathology, 1989. 35 years later, he's retiring and is going to turn over the editorship of that journal. The last issue of his editorship will come out this fall, and a couple of current students and I have put in a big piece about both topics you'll hear about today. So Ted Beauchesne and I also have edited 3 editions of a textbook on developmental psychopathology for advanced undergrads and grads. And among the principles, which again, we could spend the whole time talking about, how if you want to know about ADHD, you better know about the normative development of self-regulation and executive functions, and vice versa, normal developmental interplay. Much is not linear across development. Reciprocal transactional models are par for the course. Multiple levels of analysis, which really came from embryology and systems theory, all the way from molecules to individuals, families, schools, to cultures, nations, policies, and we'll hear a little bit about that today. Equifinality: multiple roads lead to Rome, many pathways toward the things that we consider as conditions or disorders in the DSM, and from a given risk factor, many different spreading outcomes, multifinality, showing the transactional pathways involved. Homotypic continuity: tantrums predict tantrums predict tantrums. Heterotypic continuity: maybe there's an underlying trait or set of predispositions that over time is stable, but the forms of those behaviors change with development, which means there may be more stability than we think, but we have to think very broadly about psychological constructs. I'll have a little bit to say about genes and experience, which is very clear in David's field of bipolar disorder, and show you some data from our lab showing how trauma and heritability intersect in girls with ADHD. And of course, we talk too much about psychopathology and not enough about resilience and healthy outcomes. So what's going on these days? I'm not going to read every line of the slides because time will run too short. In teens over the last 50 years, age of onset has gone down, especially for girls, especially for depression and anxiety. And prevalence, even though we don't have great measurement in variance, seems to be going up, especially recently. And if you're not sure about the diagnostic entities, all you have to do is look at a hard indicator like attempted suicide or completed suicide. It's hard to argue the validity of those measures, and things are at a crisis level at this point. In March 2020, adults on average spiked in depression and anxiety for about a year, and then again, on average, returned to baseline. Kids have not returned to baseline, even with the pandemic seemingly over, or is it, which is a huge question. And last spring, CDC, Centers for Disease Control and Prevention, in one of their surveys, they never used to do developmental disorders, now they do, showed that on the day of that fairly extensive survey, 32% of high school girls in the United States were sufficiently despairing to be thinking hard about suicide. And this is, again, unprecedented. We've never seen data like this before. Second leading cause of death, we all know this, culture of despair. And to zoom out for a minute, it's very clear that the first 10 years of life are the risk period for boys for a lot of neurodevelopmental problems, autism spectrum, ADHD, Tourette, early onset conduct disorder. If you're XY in utero, what happens? What does that little puny Y chromosome do? It tells the developing body to secrete androgens, which do a lot of things to make a male and also slow brain development. So it's little wonder that boys are at greater risk for neurodevelopmental disorders. Girls come out of the chute for the first few years of life way ahead of boys in many domains. But it's the second decade of life with, I just saw the recent data, the average age of puberty in the US now for a girl is 11.9. It's gone under 12 for the first time. And with the expectations that are impossible, which I'll talk about in a second for girls, the question is the nature and nurture predominance of mental health problems, especially internalizing problems in girls during the teenage years, seems to be going up over the last decades, which would be hard to attribute to genes. I think Darwin would turn over in his grave, right? There has to be some cultural influence or epigenetic forces driving this fast increase. So I wrote a book 15 years ago called The Triple Bind, which is doing a little bit of a resurgence these days. And here's what I hypothesized with my co-author Rachel Kranz back then. Throughout history, and I'm very broad strokes here, if my mother were still alive, I wish you would tell her that I did keep my jacket on for 8 minutes, but that's enough. Girls are expected to be the caregivers, the nurturers, the empathic ones. But over the last 50 or so years, civil rights, women's movement, et cetera, girls are now expected to, and do, outperform boys academically, athletically, Title IX, et cetera. And so it's really hard to come in first place in the Paris Olympics coming up in the women's 400, but your competitor has stumbled. So do you help her or do you win the race? So there's a bind already. And what we talked about in 2009 was, which is a trend that's been building for a long time, to be a real girl, you have to do that effortlessly and in a very sexualized, hot manner. It's okay to be kind of geeky as a guy and succeed, but you can look in rock music and you can a lot of fields of endeavor. Looks and appearance really matter for girls. So if you buy those 3 premises, girls are going to internalize and ruminate, and wait till we get to social media in a minute, Sleep is going to get disrupted. Every study ever done, especially by my colleague Matt Walker up at Berkeley, shows that sleep is not only essential for cognitive performance and memory, but with sleep deprivation, you remember all of the negative words on the pre-word list you got and hardly any of the positive words. It has big impact on positive affect and the lack thereof. How do you succeed when it's impossible? Learned helplessness, Seligman's paradigm with dogs back over 50 years ago. And from some of our focus groups, it's as though the teenage girls that we talk with as writing this book were reading from Seligman, how utterly helpless they felt to make any change in the world or for themselves. Sexual objectification can be Playboy centerfolds for decade after decade, and now, of course, intensified with social media. If you haven't read it, former Berkeley postdoc Barb Fredrickson, who's now at North Carolina, did her famous swimsuit study when she was an assistant professor at Michigan a long time ago. And very long story short, if you were in Psych 1 and getting research credits, you'd go in for you worked on math problems for 20 minutes. That's an easy way to pick up a half-hour credit, except you were randomly assigned to go behind the screen and put on a maize and blue Michigan sweater and trousers or a bathing suit. Now, it wasn't a bikini, it was a one piece for gals and not a Speedo, but regular trunks for guys. And then in an isolated room that had one prop, a mirror, you did math problems for the next 20 minutes. The boys in the swimsuits compared to boys in the sweater and trousers, afterwards on the post test, they said, I feel a little silly, a little proud and kind of great, and actually did slightly better on the math than in the sweater and trousers. And the girls felt humiliated, ashamed, chagrined, and tanked on the math, which is, of course, the stereotype threat girls aren't supposed to do well at. Of course, in high schools now, girls do better in math than boys in states where they're allowed to take a lot of math classes. So Fredrickson has done a lot of work on sexual objectification over the years. We could talk about true and false self. What we didn't know in 2009, and unless you've been under a rock for a long time, social media has taken into directions that we didn't understand would go. So there's a huge controversy. If you're really interested, I'll go to the bottom of the slide, read John Haidt's new book, and then read Candace Oger's review of the book in Nature from 2 months ago. The gloves are off. Social media has ruined brain development for teenagers, especially girls, permanently, versus not so fast. What are you talking about? Yes, it could be a problem. Really interesting debate. The meta-analyses that Jean Twenge and John Haidt have done the last couple of years clearly show one thing, though. Even controlling for baseline anxiety and depression, exposure to social media has a big impact, especially comparative social media, TikTok, et cetera, for girls in terms of later decrements in mental health, and not a bit for boys. So sex is a huge moderator, whatever your views about the permanency of such effects. So with that in mind, we're going to talk about ADHD for a minute and why 27 years ago this year, my team and I wrote a grant to NIMH to use our summer camp naturalistic methodology to study girls with ADHD. So ADHD, like everything else in the DSM, there's only one problem with the DSM, which is its title, the Diagnostic and Statistical Manual of Mental Disorders, because there's not a disorder in it. If a disorder is a syndrome with a unified cause. And ADHD is clearly with the underlying symptoms of inattention and disorganization and hyperactivity and impulsivity, it forms almost a perfect bell curve. Both those dimensions and the categorical diagnoses are heritable between 0.77 and about 0.86 in many twin and adoption studies. This isn't a fluke finding, rivaling but not quite up there with autism spectrum and bipolar disorder. Heritability is destiny, right? Wrong. Because for an individual context, even for 100% heritable conditions, like PKU, the right diet can normalize your IQ later. So heritability does not imply destiny. So we could talk a lot about ADHD, but here's my brief intro. I don't work for pharma or consult for pharma. So under the doctrine of fair use, I'm going to show you 3 advertisements for ADHD meds over the last 20 years. Now, what's the message? How many countries allow direct-to-consumer ads, by the way? New Zealand and the US. US changed its policy, FDA changed its rules in 1999, so that the ads weren't just in medical journals, but they were on late night TV and Ladies Home Journal, with the idea that this would promote competition and lower prices. Clearly not the case, and that it might reduce stigma. Open question. So here's our first ad from a little over 20 years ago for Concerta, which is a patented formulation of good old methylphenidate Ritalin, embedded in a little firm up in the Bay Area, to have it scored out through, well, you swallow this little plastic thing in the pill, 2 laser hold tubes inside one another, and the gastric juices in your stomach scored out the methylphenidate over 10 to 12 hours. Probably the most effective first long-acting form of methylphenidate. So the ad here is kind of classic. White middle-class mom, white middle-class son. We know now from Centers for Disease Control, Black kids are slightly more likely to have ADHD than white kids now. Girls, we'll talk about more, not as many as boys, but rising to probably the true level. What does mom say? When I give Jason his Concerta, I see the real boy, not these troublesome, bothersome problems. So if you think about it, it's the world's first anti-stigma ad for an ADHD medication, right? The medicine removes the stigma, you see the real person underneath. Now, whether that's true or not, we could talk about all week, but it's a fascinating premise. Now, a few years later, here's an ad for Adderall XR, extended release, another way of extending, in this case, dextroamphetamine, amphetamine salts over 10 or so hours. And of course, the market here is adults, because we didn't used to think ADHD lasted past puberty, and we didn't used to think that girls could have it or experience it, and they do. So if you've got really good eyes, you can read some citations to the psychiatric literature that if you're an adult with ADHD, about twice as likely to get divorced and about a third more likely to experience major depression. If only things were that simple or linear, but many readers of the ad would think, I better take my Adderall XR and I'll stay hitched and I won't get depressed. Part of the controversy over the whole topic. So here's an ad from the last decade. Just before he retired, here's Shane Victorino, the first Hawaiian American to play Major League Baseball. 2 drug firms and 2 Chad and Ada national ADHD advocacy groups got together to do an anti-stigma campaign about ADHD. And Shane was the poster child. He won a World Series ring with the Phillies and with the Red Sox, power hitter. Other pictures, his beautiful wife and kids out in Hawaii by the pools, et cetera, et cetera. So Shane says, the slide was too big, I had to cut it off a little bit. I didn't outgrow my ADHD, that's why I'm telling my story. Great anti-stigma message. But there's another more subtle message, perhaps, that if Shane wants to take stimulants during major league games without getting thrown out for half a season, because stimulants are performance enhancers, he has to disclose and get a medical diagnosis and take the commissioner's office. So when I last checked a couple of years ago, I check this out now, post-pandemic, Major League Baseballers have about twice the rate of ADHD exemptions as National Hockey League, NBA, what am I forgetting, and National Football League, which could be a fascinating epidemiologic fact, but there is another explanation. Baseball is the most boring sport ever invented in the history of sports. It's a little faster now with the clock on the pitchers and all this, but in the 9th inning or extra innings, that focus edge may be important, the difference between victory and loss. So this is part of the controversy. Are we afraid of getting an ADHD diagnosis for our kids? If we're an adult and it's legitimate, or you get a doctor who says it's legitimate, will that give you the performance edge? And so again, this is part of the controversy. I think it's an interesting way to introduce the whole topic. So ADHD is a misnomer. There's no deficit in attention. The deficit is in a broader concept of self-regulation, executive functions. I mean, just think of hyperfocus. Many people with ADHD forget to eat lunch and dinner when they're engaged in a very engaging activity. So we have to consider regulating attention, regulating motivation across the vicissitudes of a day, a school year, et cetera. We could talk all morning about executive functions, whether there's a dopamine deficit, lowered intrinsic motivation, maybe it's response inhibition, which is Barclay's theory, except response inhibition may be a kind of executive function. It's clear that, and if there was more time, I'd have a lot of slides on this, there are multiple pathways from genes, from low birth weight, from severe trauma to later ADHD. It's not just one thing. Well, if it's that high, as I said a couple of minutes ago, I guess parents really don't matter. Well, I'll show you some data from a clinical trial that parents really do matter and schools really do matter. Context can shape individual trajectories, even though the majority of the risk for who has high levels of symptoms and who doesn't is conveyed by genes. And you see some former trainees and mentees of mine in the lab, some of whom are at UCLA now, in some of the citations listed. Richard Scheffler and I, hey, if you don't get interdisciplinary, I met Richard Scheffler 15 years ago at a Berkeley conference where actually the faculty spoke with one another. He's a health economist. At the talk I gave when I said that the cause of ADHD is compulsory education, sort of truly, at least it reveals it. And he came up to me afterwards and said, I've always thought of ADHD as a performance issue. It ruins school performance and job performance. So we collaborated on a big book project with Robert Wood Johnson funds. I learned a ton about how to do fancy statistical modeling from that. So you need a bunch of symptoms of inattention. You need a bunch of symptoms of hyperactivity, impulsivity, or both to have the combined type. They got to be present since you were a kid, although this is a huge controversy today. Do you wake up one day at 30 or 50 and have ADHD? Probably not. There probably have been signs earlier, especially in girls, where it wasn't diagnosed and there was a lot of stigma, et cetera, et cetera. What's the average length of time to get an ADHD diagnosis in the United States today? About 12 to 15 minutes in a pediatrician's office with no specialty training. No wonder we overdiagnose, especially in boys. We underdiagnose until recently, especially in girls. The bias against people of color having ADHD. In every other country that has professional assessment and treatment guidelines, the treatment of choice for ADHD first line is behavioral psychosocial intervention and medication if needed. The United States is the only country that says medication is the first line treatment and then add psychosocial treatments if needed. Now that's not true for preschoolers, but for grade schoolers it's true. And if you're on Medi-Cal or Medicaid, ADHD is covered now for diagnosis. And ADHD is covered for treatment. What treatment? Only medication. No coverage under public insurance for psychosocial behavioral interventions. So got very interested because we'd run treatment studies and summer camps. Families of girls would apply. There was never enough of them. The lore said 30, 40 years ago, girls really don't have hyperkinesis or ADHD. The epi studies around the world now show more boys than girls have ADHD, 2.2, 2.3, 2.4 to 1, because some of the reasons I mentioned a few minutes ago. But we didn't really have, except for the Biederman group's pretty much white middle class follow-up study, any longitudinal data. So we wrote a grant to NIMH in 1994. They said, I don't know, I don't think this is well enough justified. Those were the days when you had 25 single space pages to write a federal grant, which was really good in some ways. And we went for it. And just showing how secure the grant funding was. In those days, you get your summary statements and scores via fax. And so off the fax machine, I was there in the office looking, our percentile for the revised grant was 0.01. We were the top funded rated grant in NIMH that year. People were starting to realize maybe there's something here. So we set about using our naturalistic summer camp methodology to learn a lot, not just from a clinical assessment, but observations of behavior, peer sociometrics, achievement neuropsych testing, to understand what ADHD looks like in girls. We also told the families, I remember those meetings as though they were yesterday, orientation to the summer camps, we will follow your daughters if we get funded for the rest of their lives. And it was an interesting expectation because the phone started ringing a couple of years after the first summer program. We ran 3 consecutive for different samples, and the parents said, when's that lifelong study happening? Create an expectation. And of course, you need to get funding in order to do it. free summer camp, very respectful treating of families and kids by the staff. So what we started was the Berkeley Girls with ADHD Longitudinal Study, conveniently acronymed BGALS. And we learned a lot from those summer camps, which were really fun. Girls with ADHD were very impaired in a lot of domains that boys with ADHD have traditionally been found to be impaired in. But we started the longitudinal study because we published enough. So over our first 4 waves, because we're relentless and because of the expectation we created, we got 92 to 95% back, either flying to their homes or bringing them into Berkeley for pretty detailed follow-up assessments. It's a very diverse sample, 140 girls with ADHD combined or inattentive, 88 neurotypicals. And we just have completed our 5th wave, which we started during the pandemic, so it all had to be online. We won't have the 90+%, we'll be in the 80s for our follow-up retention rate, to look at what happens over time for girls with ADHD. So to move kind of quickly, we published this paper in 2012 at our 3rd wave. The average age was about 20. And these are pretty much dichotomous measures. Had you attempted suicide, I think the slide's a little big, it got cut off. Red bar is ADHD combined presentation in girlhood, now 10 years later. 23% had made a serious attempt on their lives. 8% of the inattentive, 6% of the neurotypical comparison. 6% seems high, that's the national average. This wasn't a Bay Area skew. In terms of beyond very lightweight, cuticle picking, hair twirling, non-suicidal self-injury, moderate to severe, 51% of the girls with ADHD combined were engaged or had been over the interim period in pretty severe NSSI, a little over a quarter of the inattentive group, and 19% of the neurotypicals. 19% of the neurotypicals? That's the national average back then. What do we know now from recent CDC data is the average age of onset of non-suicidal self-injury in girls? 11. Getting younger and younger all the time. So what does a researcher think of when you think of baseline summer camps, early adolescent, mid-adolescent follow-up, now early adult or emerging adult follow-up? What might mediate? Because we did a big assessment when they were in their mid-teens. In terms of predicting how severely the young women were engaging in NSSI, the only 2 significant mediators were a good old neuropsych test, a cancel underlying test, a test of response inhibition, and the parents and teachers and girls composite of their acting out delinquent behaviors. So here's the same slide, a little test of your working memory. It looks the same, except the outcome is now attempted suicide, and the only significant adolescent mediator was parent, child, teacher reports of anxiety, depression, social withdrawal, internalizing. So NSSI and suicide are linked. One of the biggest predictors of attempted suicide in one's 20s is a history of NSSI in one's teens, but they're partially independent. Dr. Meza is in the audience, and her master's thesis involved her foray into peer relationships. So during our summer camps, we got peer sociometrics the classic way. It's hard to do that in public middle schools. It would cost a fortune and take an army. So what was the significant mediator of, and she uses predictors, both commission errors and ADHD symptoms and ADHD categorical diagnosis, so don't worry about that. Peer victimization, the girl's own report of physical or relational bullying by her peers was the explanatory factor for how severely she was self-injuring. And the teachers, Tom Deshawn, our late colleague at Arizona State, invented a scale where teachers estimate the kids' popularity, middle schoolers and high schoolers. And the teachers report that this girl was pretty much rejected by her peers was the significant mediator of attempted suicide 5 years after that. So again, we see that the peer domain is important, but there may be importantly nuanced differences in what the predictors are. Mediators in this case are. Maha Gundelman's master's thesis, she's now a neuropsychologist up at the Bay Area. She spent a year training a team through all of our 228 charts to look for clear presence of physical abuse, sexual abuse, or neglect, and all blinded to diagnostic status. To make a very long story short, if you were one of our 140 girls with ADHD back in girlhood, and you had experienced physical abuse, sexual abuse, and or neglect, or some combination, 35% had made a serious suicide attempt through our third and now our fourth wave, late 20s. If you are a girl with equal levels of ADHD, adjusting for pre and perinatal problems, adjusting for adoptive and foster placement, adjusting for social class, it was 1 in 7, 14%. So the odds ratio, taking account covariance, is 3.84. I thought ADHD was heritable. Families and trauma don't have much to do with it. David could cite better than I can the large studies in bipolar disorder, which has an even higher heritability than ADHD, whereby the experience of physical or sexual abuse during youth or adolescence for people with bona fide bipolar disorder raises the already astronomical suicide risk by an additional 50%. It's not genes or environment, it's genes and environment. So some of our work looking at other domains, in another study Maya Gundelman led, we found that the girls with ADHD were 3.5 times more likely than the neurotypicals to experience partner abuse, intimate sexual victimization by emerging adulthood, or wave 4 we followed up by kind of young adulthood. The significant mediator is in middle school and early high school, how poorly you're doing academically. It's really good to get ADHD symptoms reduced, but peer relationships and academic performance are the targets we should be having, not just symptom reduction. Here's another outcome from our fourth wave. 10.5% of our neurotypical girls had had 1 or more unplanned pregnancies, and 43% of the girls with ADHD. You really don't need a significance test, right? That's a big difference. And what was the adolescent mediator? Low academic achievement again. This is a huge problem for girls, maybe even more so than boys with ADHD. And medicines reduce about half the gap of achievement test scoring, but not the full gap. So in this last issue coming, it'll be online next week, and this fall when it's actually bound in Dante's final issue of Development Psychopathology 35 years later, this is the citation for a mega review we kind of did of how our developmental psychopathology procedures informed our ADHD research, and what I'll talk about next, some of our stigma reduction research. It's a book I did last year from Guilford Press. It took till page 2 of the book. I couldn't get it on page 1 because it's a book right for parents about raising a girl with ADHD, to bring up 2 principles from dialectical behavior therapy, even though it's not a book about dialectical behavior therapy. If you have a daughter with ADHD, you better radically accept that this isn't the daughter you might have expected. She pushes limits. She's not so compliant. She's not a little angel. She has trouble in school. Girls aren't supposed to have trouble in school. And then another paragraph later, you also need to radically commit to a medication trial if it's indicated, and a reward program at home, and getting the school on board, because it's the environmental contingencies that are going to make the biggest impact on her life growing up. Treatment. 2 slides. Before we get to the first, across many controlled trials of stimulant medications and non-stimulants too for ADHD, if you want to reduce parent and teacher ratings or objective indicators of ADHD symptoms, if you get the right dose of medication, it does a really good job, and all of the parent management training and school consultation in the world barely puts a uptick on that. But if you want to improve academic achievement and peer relationships and depression and anxiety and conduct problem symptoms and parenting, you better darn well do combined treatment. So from the good old multimodal treatment study of children with ADHD, nearly 600 kids with ADHD combined, 6-site study done a long time ago now. Keith Connors et al., I'm part of that group, formed a different composite measure, not just ADHD symptoms, but ADHD symptoms, internalizing symptoms, externalizing symptoms, social skills at school, reading and math performance, and both observed and parent reported authoritative, warm and limit setting parenting. What does best? The combination for 14 and a half months of really well delivered medication, 35 parent training sessions, school consultation, and a kind of remedial, if you will, skills-based summer camp. Medicine alone helped, the behavioral treatment alone helped, even our community group, 2/3 of whom got medication, but not very well delivered medication, everybody improved. But if you want to affect impairment, combined treatments are pretty much the rule of thumb for ADHD. And now here's a slide that'll take a lot more explanation. I was the lead author on this when the MTA results were first getting published. And I hypothesized, much to the chagrin of some of my fellow investigators at other institutions who were, I think, embroiled in how heritable ADHD was. We hypothesized before the trial began that improved parenting, both observed on videotape and from parent reports and kid reports of their parents' parenting, that the parents who would during treatment become better limit setters and be warmer, this authoritative blend, would have the best outcomes. So the red line here is people getting the combined medicine and behavioral treatment and the single treatments and the comparisons. The red line goes down steepest, and this is the normative range right here. The kids whose behavior at school was normalized 14 and a half months later were the kids who got the combined treatment and whose parenting scores over 14 and a half months dramatically improved into the authoritative range. Lack of authoritative parenting didn't cause the ADHD, but the promotion of authoritative parenting may change the trajectory of ADHD. So as the clock is ticking down, stigma, our final topic, will go very quickly. What does stigma originate from? It's an ancient Greek word meaning a brand, or the metal rods that were heated to put that brand in you, a mark in your skin. Everybody knows you're different. Today, stigma is much more psychological. Hitler and his cronies branded people left wrist in concentration camps. Many countries on earth literally branded people who are HIV positive in the 80s, to keep away. But most branding today is a psychological attribution, if you will, rather than a physical one. Lots of groups receive stigma. I put left-handedness up there as an example. My little sister back in Ohio, when we were growing up, our maternal grandmother did not want her to be left-handed. Remember, sinister from Latin's left. Today, if you're left-handed, probably have good spatial abilities, probably get into MIT. It's kind of awesome, right? So as societal norms change, as contexts, cultures evolve, what was formerly stigmatized may not be as much. But what are the bottom three? What are the conditions you might have or the attributes you might have that lead to the most stigma in the United States in the early 2020s? Mental illness, substance abuse, or being unhoused, being homeless. The bottom three still. I wrote a book on this topic 16 years ago, volunteers for a second edition. It really needs updating. And I chose for the cover art Hieronymus Bosch's painting, now hanging in the Prado from 1496, The Extraction of the Stone of Madness, or The Extraction of the Stone of Folly. So, quick art history. Here we see the surgeon, but the surgeon's wearing a wizard hat. So Bosch is already messing with us. Extracting the stone, trephining and taking the rock, the cause of mental illness. Out of the gentleman's head, the priest is giving a blessing. The patient is, help, what's going on? No anesthesia. But if you look closely, it doesn't look like a rock is emerging. You see little tufts. What was the name for mental illness in Amsterdam and outlying Holland in 1496? You were called a tulip head. Bosch was painting that the surgeon wizard was removing a tulip. Pretty pertinent 528 years later. Does having a diagnostic label help you? Or is the label the source of stigma? I mean, it's still an issue today, which is why I chose this for the cover art. If society stigmatizes you publicly, it's very likely, although not inevitable, that you will show what's called self-stigma. And there's validated scales of this. Beyond anxiety, depression, how much do you feel you're really not deserving because of the label you have? Goffman, who wrote the Bible on Stigma in 1963, said in one chapter, if society bothers to stigmatize a group, it's only common courtesy that they would stigmatize anybody associated with a member of that group, like their families. And of course, in our field, families were the cause of autism. The refrigerator parents, the schizophrenic mothers, cause of ADHD. Who else spends a lot of time with people with mental illnesses? Psychologists, social workers, psychiatrists. If you believe Otto Wall's national study from some years ago of 2,000 people with bipolar disorder, schizophrenia, or severe depression, among the top 3 for almost every individual sources of stigma were their providers. My shrink never thinks I'll get a job, finish school. All the way to Gomer, get out of my emergency room. We take physical injuries. We don't take people who put drugs in their system or mental illness. And then structural stigma, Mark Hatzenbuehler, our colleague who's now moved to Harvard, from Columbia, met with him when he was still a grad student, and some of our structural modeling that Scheffler and I did to show that ADHD diagnosis rises most quickly in those states that have laws that prioritize test scores above all else, because there's a lot of pressure to get kids diagnosed. And he's done pioneering work, especially for sexually minoritized youth, that in those states that don't have anti-hate crime or that don't have protections, the mental illness risk for sexually minoritized youth is far higher, and their response to evidence-based treatment, CBT or DBT, is a lot less. So if we publicly stigmatize, self-stigma, courtesy, associated stigma, structural stigma are part of the mix. They was kind enough to mention another kind of madness. Here's my father and me outside the backyard of our family home in Columbus, Ohio, in the spring of 1971. I had just returned home from my first freshman year, almost a first spring break from Harvard, and Dad sat me down right before the shot was taken and told me about his lifelong supposed schizophrenia, starting out in Pasadena when he was 16, when he jumped off the roof of the family home thinking he could stop the Nazis in the 30s from taking over the free world. Classic bipolar disorder. Bipolar disorder was really not diagnosed in the US from the 19-teens till about 1970 when lithium was finally approved. And Dad spent many of his years, he was an esteemed philosopher, professor at Ohio State, studied in grad school with Albert Einstein and Bertrand Russell, but spent way too long, including many months and years when I was a kid, in some of the country's worst mental hospitals. And his lead doctor had told my mom and my dad, if your children ever learn of your schizophrenia, they'll be permanently destroyed. The family's never allowed to bring up the topic. Doctor's orders. So what do kids do when things are not so good at home or in the world, but nobody talks about it? I guess you can believe the world's a random, awful place, probably not a very healthy attribution, or you can blame yourself. Not really true, but you at least maintain a semblance of control. So I had a great childhood in many ways, especially when Dad was back. I didn't know where he was. I thought it must have been my fault. And it took his disclosure when I wasn't a kid anymore to make me change my major into psychology and study clinical psychology and do some of the work I've been doing in developmental psychopathology and in stigma. And the book goes into pretty graphic detail about his journey, my journey, etc. So I got one more minute. In the United States, people know tons more about mental illness than in the 50s. And we have measurement invariance because the same national stigma study measures have been in place. And levels of stigma have not budged. In fact, 3 times more people, if they hear the term mental illness, than in the 50s think immediately of danger and violence and aggression, probably because of unintended side effect of deinstitutionalization. Our colleague Bernice Pesco-Solido, I was just in Iceland with last week. The World Psychiatric Association ran a Together Against Stigma international conference. Her national stigma study results from just a couple of years ago show for the first time social distance, perceived distance, the distance you want to keep from someone with depression had gone down by a D of 0.4. but it had gone up for substance abuse and schizophrenia. So we're in a mixed blessing kind of period now. Why would ADHD receive stigma? It's kind of mild, right? Compared to bipolar disorder, schizophrenia. Well, some of the outcomes aren't mild, and everybody knows you can control your ADHD, so we ascribe it to your control. And especially for girls, if you're not very social and you're not doing well academically, I think there's kind of a double or triple stigma involved. So the last slide, how are we going to solve stigma? Multiple levels. So like climate change, carbon taxes, or individual recycling, and everything in between. We need to enforce the ADA, the Americans with Disabilities Act. We need to change the media portrayals that are better than 20, 30 years ago, but not much. And some of the worst are in video games. Really, I mean, just meta-analytic review just came out last year about that. Teaching the facts about mental illness helps, but not much. It can actually reinforce stereotypes. Contact, as Alport said in 1954, The Nature of Prejudice. Contact under equitable conditions at school and the workplace is the antidote. Evidence-based treatment, what was the most stigmatized disease on earth in the 80s? HIV. And what reduced the stigma? The antiretrovirals. Not a cure, but a way for recovery for a long time. And in some of the studies, both in Africa and the US, random assignment to knowing a person has that kind of treatment versus not reduces stigma from about 80% to 15%. So the search for treatments is crucial for reducing stigma. And humanization, again, not just athletes and celebrities, but everyday people, just as with breast cancer for women and prostate cancer for men. If everybody talks about it, the policymakers can't ignore it. So this has been a lightning fast set of slides. It's a deep honor to have this first lectureship. Met Richard and his family last night. What an incredible honor for psychology here at Semel. Great to be back at UCLA. I come back every once in a while. And if there's anything to take with you from my all too brief remarks, science and humanization and anti-reductionism, it's genes and biology and experience coming together. So thanks for listening to my remarks.
Thanks very much, Steve. Brilliant talk. We have a couple of minutes for questions, and we may have a few online as well. Questions for Steve?
Let me stand up.
Back there.
Thank you. Other than maybe the intensity of the numbers that you mentioned, social media, are the factors roughly the same for boys to girls? Social acceptance, academic.
Yeah, largely, if you do beyond ADHD, you go to wider domains. The risk factors for boys to predict academic and psychiatric outcomes are largely the same, but trauma may be particularly salient for girls. And in the social domain, because of, again, not to stereotype, girls' kind of inherent or innate need for social connectedness, et cetera, social rejection may be a more powerful predictor in some meta-analyses for girls and for boys. Well, I have a question. Could somebody turn on the air conditioning? No.
Other questions? We have one. Yeah.
I'm with stigmatized people in the United States, that women who use alcohol excessively during pregnancy.
Right.
And it's sort of the same thing. They have stigma not only from the world, but also from their providers. And getting help is very difficult, and even making a diagnosis of their child, who needs to ask them if they're alcohol during pregnancy. And of thousands and thousands of studies, we've talked about the developmental problems with kids with previous exposure. There are only 12 studies now coming out of positive psychology where they actually are trying to talk about positive aspects of being exposed to alcohol during pregnancy.
Yeah.
So I really empathize with what you're saying, and it's really quite important.
So for those of you in Zoom land, the question has to do with the utter stigma against parents who use substances, especially moms.
Now dads.
What's that?
We're finding dads contribute academically.
In APS's journal, Psychology and the Public Interest, PSPI, Psychological Science and the Public Interest. And Crendel and Bria Perry of Indiana wrote a big review on stigma related to substance abuse last year, and I did one of the invited commentaries. And if you think the stigma against schizophrenia and bipolar disorder and anxiety and depression are bad, against substance abuse, it's another order of magnitude higher. It's a big issue.
It's hard to get help.
That's right. Do we have any Zoom
Yeah.
questions?
What role might the ongoing corruption of our environment and food supply play in the concerns you raise, especially hormones in dairy and meat, contamination of our seafoods, ubiquitous plastics, and so on?
So it's in the news a lot now with the invisible plastics that we can't see that are everywhere. So in the autism world and in the ADHD world, there was some years ago some overselling of dietary treatments, secretin for autism spectrum, the Feingold diet for ADHD, not really evidence-based. However, in terms of risk factors, environmental toxins, crowded neighborhoods, polluted neighborhoods are now coming into their own as viable risk factors for later a bunch of neurodevelopmental outcomes. So it would take probably another lecture to answer the question in full, but I think the research is showing that especially, the conditions associated with urbanization and poverty and low quality neighborhoods, not just socially, but physically, not just lead, but other toxins. These are big risk factors. Oh, right here.
On the slide right before this one, I'm really curious what you think about the role of the age of smartphones and social media on any of those things that we do to combat.
So, I mean, what changed 4.25 years ago? Most therapy was done online. And apps are everywhere. If I had a nickel for every email I get every week about the next app for ADHD, I would have retired, some years ago. How good are they? How good is app-based treatment alone? What about for adults versus for kids? I think Zoom therapy isn't very productive for kids, et cetera, but maybe for families. But if we have a generation that's grown up, wait a minute, addicted to phones, you can deliver evidence-based treatment, as Dr. Builder and I are doing, both at UCLA and Berkeley with a small business grant, to see if the right kind of app can really enhance attention for young adults with ADHD. More power to it. But my sense is, just as social media isn't going to replace real relationships for teens, media-based apps are one part of the armamentarium, but they're not the full story for mental and neurodevelopment. Do you have any more?
Yeah, one more. There's a tremendous push in Southern California, middle and high school programs to eliminate all separate classrooms for special ed. Those students with ADHD and learning disabilities are in large classrooms, learning alongside peers. Given your talk and the concept of stigma versus low academic achievement, do you have any thoughts on this as an educational trend?
Boy, do I have a lot of thoughts. So my wife's in the early childhood field. And one of the big points of contention about Head Start and other secondary prevention, how do you get into Head Start? You have income below a certain level. And Head Start promotes academic performance for a short term. Gains are lost unless it's sustained. They have longer lasting effects on preventing delinquency and other psychosocial outcomes. But the biggest catch is that when you stratify, the only kids in Head Start are kids of poverty. The outcomes are better if you have mixed preschools of all social classes. Now go up to K through 12. I mean, the whole idea of normalization and inclusion was we don't pull kids out and have only special schools. We unify, which works to an extent, but what about in a classroom of 35 and there's 3 kids with ADHD and there's no aid? I think the jury is still out about what's the right time and for what learning or behavioral or emotional conditions. Some special, more numerically better ratio support will help versus keep the kids mainstreamed as much as possible. And it's a huge issue. And I wish I had the answer.
I think one of the things we're seeing in autism, which I'm sure you've heard about, is young women referring themselves
hoping to get a diagnosis.
The TikTok phenomenon for ADHD, right?
And sometimes they're right, but sometimes they're not right. But it seems, I think we tiptoe around the issue of stigma because they hope with this diagnosis, they will be more acceptable.
That's right.
But it isn't a diagnosis that actually fits them. And so do we take that community away from them?
Boy,
What do you think?
I mean, social media giveth and taketh away, right? I mean, you know, look at a lot of websites out there for self-harm.
Yeah.
You know, it's confidential, long sleeve sweatshirts, you don't want your parents or teachers or peers to see. And those same sites are the best self-help manuals for how to injure yourself more severely.
Yeah.
It's like the old pro anorexia sites. So, this was a big phenomenon, latter stages of the pandemic. Go on to TikTok, very supportive community of women who never got a diagnosis of ADHD, probably should. And just answer these 4 questions and you have self-diagnosed. And then in some of the less scrupulous ones, here's how to mail order your stimulants without a doctor's permission. Now we're into real danger because I didn't even talk about, remember with Shane Victorino? Well, maybe we should put stimulants in the water supply. Where's fluoride? Right. What happens if you don't have ADHD and you start to take stimulants as smart pills or as party pills? Party pills, well, you can get really drunk at a party or rave, and if you take stimulants, you won't pass out and you can keep drinking, right? About 20% of such neurotypical youth will become addicted to stimulants, and about 1 to 2% of youth with young adults with ADHD. So the diagnosis really matters, and having online access to a community of support is great, but I wouldn't trust those diagnoses very far. But I can really understand the want for belongingness and community. Gee, we're way over time.
Yeah.
In this
Wrap
hot
up.
room.
Thank you.
What a morning. Thanks, everybody.
Thank you.